Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features content regarding medical considerations in aging patients with HIV. During this podcast, Dr. Jonathan Appelbaum, Professor and Chair of the Department of Clinical Services at Florida State University College of Medicine in Tallahassee, Florida, discusses medical and psychosocial challenges faced by older patients with HIV, including consequences of early experiences in the epidemic, such as late HIV diagnosis and low CD4 cell count nadir, incomplete or short-lived virologic suppression with early regimens, and toxicity associated with early antiretroviral agents. For more information about Dr. Appelbaum and for a link to the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Appelbaum has to say about medical challenges in aging patients with HIV.
Welcome to the program. My name is Dr. Jonathan Appelbaum, and I'm professor and chair of the Department of Clinical Sciences at Florida State University College of Medicine in Tallahassee, Florida. If we look at the research that's been done, and in most of the clinical trials, particularly the clinical trials having to do with medications, older patients are less represented than younger patients. And in fact, for many years, patients over the age of 65, and particularly those patients who had multiple comorbidities, were actually excluded from clinical trials. That is beginning to change. And in fact, many of the clinical trials often will do sub-analyses looking at their patients who are older. Now, because of the way the CDC has defined older patients with HIV, many of those divisions or many of those, the times when they've looked at the data in older patients, they look at age 50 and above, which, may be valid, but those of us who care for older patients are really particularly interested in the older age group, 65 and above. And now as more and more patients are living longer, I think many of us are looking at a population that's 70 or 75 and above and seeing how they are doing in various clinical trials. Because older patients often have underlying renal disease and or underlying hepatic disease, many occasions those conditions will exclude them from clinical trials. Another example of where we need more data on older patients with comorbidities who are living with HIV. When we look at older patients compared to younger patients living with HIV, besides the fact that we don't have a lot of clinical trial data, I think the considerations that we need to take into place are the fact that many of these patients suffer from many other illnesses, comorbidities, and there are a number of psychosocial issues that are common in older patients, particularly stigma from having HIV for many years, loneliness, social isolation, and we can't forget underlying mental health and substance abuse issues. So there are a lot of issues, I think, that need to be taken into consideration when you're caring holistically for older patients living with HIV. When we're talking about older patients with HIV, we're really actually talking about different cohorts, different groups. We have the group that was diagnosed many years ago and has lived with HIV for many years. And then unfortunately, we have those who have been recently diagnosed. So they've been diagnosed at an older age with HIV. And I think they tend to be two different groups. The group that has been living with HIV longer often came through the early days or middle days of the HIV epidemic before we were using highly active antiretroviral therapy. So they may have been on sequential monotherapy, dual therapy, went through the era of boosted protease inhibitors and then RTIs, and then now the era of integrase inhibitors. So many of these patients have been on multiple ART regimens. And then the longer that they've been living with HIV, I think the more likely they're going to have many more comorbidities, renal disease, liver disease, lipoid dystrophy, cardiac disease. So, it's a different cohort than patients who were fairly recently diagnosed with HIV and are over the age of 50. While they may have comorbidities, they don't have the accumulation of a history of antiretroviral therapy, which we know has downsides. So the other piece when we're talking about older patients living with HIV is that many of our older patients, when they were diagnosed with advanced HIV disease, low CD4 count, very high viral loads, and many of them had opportunistic infections that were treated. We know that low CD4 counts for long periods of time have adverse effects, including prolonged suppression of the immune system, increased risk of cardiovascular disease. The consequences of prolonged high inflammatory states have, adverse metabolic consequences. As I mentioned, cardiac disease, diabetes, bone disease, all more common in patients who lived with severe immune suppression for many years, as opposed to many of the patients, thankfully, that are being diagnosed now. They're diagnosed, even though they're older, they're being diagnosed earlier in their HIV disease. So they don't necessarily have those adverse consequences. But that's not to say that we don't still see patients who present with advanced HIV. Unfortunately, we do. The challenges of caring for older patients with multiple comorbidities is the fact that adding HIV onto underlying problems like diabetes, hypertension, obesity, hyperlipidemia, you name it, cardiac disease, renal disease, liver disease, it just compounds the approach. And there's this concept of multimorbidity. It's a geriatric concept that states that when you focus really on one disease in a patient who has multiple diseases, you're doing that patient a disservice, and you can actually affect profoundly the treatment and outcomes of any one and even all of the other underlying diseases. So the geriatric approach is really one more holistic. So that's a key concept that if you're not aware of that and you're caring for older patients with HIV, you may not be doing you're giving that patient the best care. The other piece is that, as we've talked before, we're not just talking about the physical illness that the patient has. Their older patients have many other psychosocial issues, mental health disorders like depression, loneliness. It's a huge issue. Many of these patients carry many years of stigma and discrimination because of the HIV and maybe other sociologic factors. And in some ways, we're ill-equipped in this country to deal with. The question always comes up is, how in a 15 or 20-minute visit in a patient living with HIV can you actually address all these issues? And I'll say that for most of our patients living with HIV, the HIV is actually probably the least concerning problem because HIV is so well treated these days. For our younger patients living with HIV, we may see them once or twice a year, check their viral load, do safety labs, and that's the extent of the visit. The approach to HIV for a majority of our patients who are doing well on antiretroviral therapy has completely turned around. So I think what this means for our complex older patients is we need to be spending more time addressing these other issues, and whether that is best served with their HIV provider or whether perhaps they need to be followed in addition by a primary care physician, or in some cases, if their comorbidities are so complex, perhaps having a geriatrician be the sort of the primary care person or the person to kind of direct the other members of the team in best serving this patient. Again, trying to care for the patient from a holistic point of view. One of the concerns that many of us have is as our patients living with HIV old age is, whether we are equipped in this country to care for them in a holistic manner. And part of this is that many of our patients living with HIV are getting their care from specialists like infectious disease specialists who were not trained to be geriatricians, or are being cared for by primary care providers who may have little geriatric experience. So the question comes up, of course, is whether we're prepared as the HIV population ages to care for these patients in the manner we were talking about. And I'm not sure what the answer is on that. The presence of a geriatric consultant who might be able to help out, I think, is extremely valuable. But on the other hand, there's a dearth of Geriatricians, if you're living in a rural area, I doubt there would be a geriatrician in a reasonable range. And then not all geriatricians feel comfortable dealing or caring for patients who are living with HIV. They themselves may not have the experience. So I think this is a workforce issue, like many others in this country. And part of our efforts to outreach and educate providers is to have primary care docs learn a little bit about geriatrics and have geriatricians learn a little bit about HIV so that everyone is kind of on the same page. When you look at these issues from the point of view of the patient, I think patients tend to identify with their HIV provider, particularly if they've been under their care for many years. Many of them look to their HIV provider as the person that's basically saved their lives. So I think patients too are maybe less willing to pivot or see new providers or have other providers take over certain aspects of their care. So I think there's going to be resistance on both sides, from the provider side and also from the patient side. On the other hand, as HIV becomes easier to manage, the HIV docs don't necessarily feel as comfortable, and they may be the ones to refer their patients for more primary care and geriatric care and to deal with the issues that we've talked about. So we've talked a bit about the similarities and the differences in caring for younger versus older patients living with HIV. Older patients may be fitting into two groups. One group that's been living with HIV for a long time, another group, unfortunately, who's been fairly recently diagnosed. They're similar, but they're also different. And in the former group, this is a group that has experienced a lot of issues during the course of their HIV disease. The loss of friends, the stigma, multiple drug regimens, perhaps multiple opportunistic infections. And many of them now are actually doing fairly well, but living with comorbidities. And then when we care for older patients with HIV, we have to remember for many of our patients, HIV is just one piece of the puzzle. There are a whole litany of psychosocial issues that we haven't really touched upon. But then there's a number of medical issues, including multimorbidity, polypharmacy, frailty, and the interaction of multiple diseases with their HIV.
Thank you very much to Dr. Appelbaum, and thank you to our listeners for joining in. As a reminder, to view the full Conversations on Healthy Aging with HIV program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back for more episodes on important infectious diseases topics. Thank you.